السلام عليكم ورحمة الله وبركاته. والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم إن شاء الله هنكمل موضوع حلقتنا عن الاميونو سبريشن اند كيدني ترانسبلانت. نكمل حلقتنا عن أدوية المناعة وزراعة الكلى. بسم الله نتوكل على الله. احنا عندنا نوعين من الانتي بروليفريتيف ميديكيشن. عندنا المايفورتيك مايكوفينيليك صوديوم انتري كوتد فورم. عندنا الاساس اللي عندنا الاول ما طلع الميكوفينيليت موفيتيل اللي هو السلسبت. وعندنا طبعا الازاسايوبرين هنتكلم عنه في البارت الثاني. عندنا الافيلابل فورم زي ما قلت لك، عندنا الانتري كوتد والام ام اف اللي هو الميكوفينيليت موفيتيل اللي هو السلسبت، والانتري كوتد ميكوفينيليت صوديوم ده اللي هو المايفورتيك. طبعا الرسمه ديت هتحطها دايما معاك او خليها دايما معاك في اي ميكانيزم فور اني immunosuppression used in kidney transplant, and most of the medication used in other um, subspecialties or subdivision in nephrology like GN or whatever. احنا عندنا المايكوفينيليت هنتكلم عنه النهارده، هو الازاسيوبرين. بيلعبهم هنا طبعا inhibit purine or DNA synthesis or activation and inhibit cell cycle and T cell proliferation. بيلعبوا على السيل سايكل الاثنين، مايكوفينيليت او مايكوفينيليت موفيتيل، وعندنا الازاسيوبرين. دايما تخلي الرسمه دي معاك عشان تعرفك كل دراج بنتكلم عنه بيشتغل فين بالظبط في التي سيلز. هنا نفس الكلام برضو، الرسمة دي تاني رسمة تخليها معاك للتوضيح أكتر، ديت بس مجرد إنها بتوضح لك الدنيا شوية. عندنا المايكوفينيليك أسيد والام ام اف والازاسيوبرين طبعا على السيل سايكل هنا بينهبت بروليفريشن. طبعا بيلعبوا على البيورين سينسز والكلام ده كله، بينهبت البروليفريشن بتاع التي سيلز. طبعا المايكوفينيليك أسيد ده عموما انهبت بيورين سينسز. بيلعبوا على الانزيمز اللي هو الفايف رايبوسايل بايروفوسفاتيت. The mainly reversible inhibitor of enzyme monophosphate dehydrogenase اللي هو بيعمل انهبيشن للانوزيم مونوفوسفات، بيتحول لجوانين مونوفوسفات وجوانين ترايفوسفات، اللي هو بالنهاية بينتهي بتصنيع دي ان ايه او برودكشن اوف دي ان ايه. طبعا دونت. ففي النهاية عموما ده الافكت بتاعه ان هو بيقلل البروليفريشن والبروليفريشن لايك الميتوزس والاكتيفيتي بتاعت التي سيلز. عندنا الانتي ميتابولايتس اند كيدني ترانسبلانت زي ما قلنا الام ام اف والازاسيوبرين. بريفير طبعا احنا بنفضل معظم، يعني لو انت عندك امكانيه الافضل ان انت تستخدم الانتريكوتد مايكوفينيلات صوديوم اللي هو المايفورتيك. وعندنا الدوز دايما بنبداهم طبعا، هي المفروض الفول دوز 720 بي اي دي، but most of the time we started Myfortic 360 milligram POQID for better GI tolerability. Otherwise, later after 1 week or upon discharge from hospital post transplant, you can transfer your patient to 720 PID. طبعا انت لازم تحط في دماغك ان هو مثلا انت لو خرجت الان على مايفورتك ما يروحش يغيروا لسلسبت، او سلسبت يحولوا المايفورتك من نفسه عشان الجرعات بتختلف. الدوز ايكويفالنت احنا قلنا المايفورتيك مثلا 360 ايكوال 500، 70 ايكوال 1 جرام فروم سيل سبت. يبقى الانتريك كوتد مايكوفينيليت صوديوم، وده المايكوفينيليت موفيتيل ده ان اكتيف فورم، والمايفورتيك طبعا اللي هو المايكوفينيليت صوديوم ده الاكتيف فورم. 360 ايكوال 500 either oral or IV and 720 equal 1 جرام بي اي دي and 180 here equal 250 بين السلسلة. خد بالك من الجرعات دي طبعا متلخبطه شويه، بس لما تشتغل في الفيلد هتعرف الفرق بين الاثنين. زي ما قلنا هو بيشتغل على الانوزين مونوفوسفات ديهيدرينيز، ان هو بيعمل قتل السايكلز او انهبيشن للسيل سايكلز عموما. فبيعمل بريفنشن للتي اند البي سيل بروليفريشن، ان هو بيعمل انهبيشن للانوزين مونوفوسفات ديهيدرينيز اللي هو الريسبونسبل عن برودكشن اوف جوانوسين مونوفوسفات. ده اللي هو ريسبونسبل بعد كده انه بيتحول ليونسين ترايفوسفات، وبعد كده بيعمل بروليفريشن او اكتيفيشن ترانسكريبشن ترانسليشن فور دي ان ايه. طبعا كل ده اللي بيعمل سيل سايكل بعد كده. فالمهم ان هو بيعمل بريفنشن اوف تي اند سيل بروليفريشن عن طريق انهبيشن اونيزين مونوفوسفات ديهيدروجينيز. بس مش عايز اكتر من كده، انا مش عايز الخبطك يعني. هنا الميكانيزم واضح وصريح. انت الميكانيزم بتاعت المايكروفينولات انهبت انوزين مونوفوسفات ديهيدروجينيز 2 enzymes, and this will end by inhibition of guanosine monophosphate transcription, and this will end by prevention of T and cell proliferation. بس مش عايز اكتر من كده من الرسمه دي. ومن الرسمه دي نفس الكلام، انا بس كبرتها عشان اوضحها لك. هنا الاكشن بتاع الايه، المايكوفينولات موفيتيل هنكرروها انوزين مونوفوسفات ديهيدروجينيز انهبيشن. نو مور جوانوسين مونوفوسفات، نو مور دي ان اي ترانسليشن ترانسكريبشن، نو مور سيل proliferation. نفس القصه هنا برضه من الرسمه دي انا عايز احطها لك عشان بس نعرفك ان المايكوفينولات موفيتيل ام ام اف ده الان اكتيف فورم. This will be dissolved in and the stomach with he love acidity media or acid media. If your patient taking a lot of pantoprazole or ranitidine, it will make absorption of this mycophenolate is low. Take care from this drug interaction. And there is an active form mycophenolate acid. This can be work on neutral media, and this is active form enteric coated is better GI tolerability, better than MMF. هنا اجين جاست عشان برضه افكرك تاني، الام ام اف او الميكروفينولات اونوزين مونوفوسفات ديهيدروجينيز انهبيشن. نو مور يوانوسين مونوفوسفات اللي هو ريسبونسبل على ار ان اي ودي ان اي ترانسليشن ترانسكريبشن. نو مور تي ان سيل بروليفريشن. بس سكت الكلام. خليك فاكر اكسكريشن 87% in urine 13% in bile but mainly in urine now by the kidney excretion. Okay, take care from the toxicity already. طبعا في سنترز بيبدا مايفورتيك عندهم عندهم الريسورس كويسه، هم بيبداوا من المايفورتيك من البدايه عشان الجي اي سايد افكت والكلام ده كله بيشتري دماغهم من الاخر. في سنتر ثانيه بتبدا بالسيلسبت، وبعد كده يحولوا للمايفورتيك او سيلسبت ويتني ماشي على سيلسبت اكسبت اف نو اف سايد افكت في جي اي سايد افكت فروم سيلسبت زي ويل ترانسفير تو مور فور مايفورتيك. في سنتر بتحب تبدا سيل سبت. خلينا بس عشان نبقى مش عايز اكرر الكلام. عندنا السيل سبت اللي هو المايكوفينوليت موفيتيل، وعندنا المايفورتيك اللي هو الماي انتريك كوتد مايكوفينوليت صوديوم. عشان هتكلم بعد كده سيل سبت او مايفورتيك. في مراكز بتبدا هنا، مستشفيات بتبدا بالسيل سبت وبتبدا 1 بهاي دوز 1.5 جرام twice daily for 5 days زين 1 جرام بي اي دي. بس معظم السنترز اللي هي يعني معظم السناتر بتبدا 1 جرام بي اي دي فروم دي زيرو، بعكس هذا السنتر. تمام. عندك وفي سناتر تانية طبعا بتبدا من المايفورتك 720 بي اي دي فروم دي زيرو، على حسب المتوفر عندك وعلى حسب الكلام المايفورتك والسلسبت. طبعا زي ما قلت 720 بي اي دي السنترز بتبدا بالمايفورتك 720 بي اي دي من الاخر يعني. طبعا وطبعا عشان تبدا العيان بتاعك هذا السيوبرين، لو انت بتفكر تبدا بهذا السيوبرين ده، طبعا الترايلز والاستادي قالت لك الام ام اف powerful or superior to azathioprine as regard immunosuppression and rejection. Only the problem with MMF in general just heartburn if your patient feel GI upset, diarrhea. The most common side effect I have one patient, two patients in clinic today. One patient already with horrible diarrhea around 10 times watery diarrhea. We did all stool workup already from stool cultures and norovirus, adenovirus, and other virus already, enteric viral panel already. All this done, all came negative. And we just decreased the dose from 720 BID because we shifted from Celcept to Myfortic, and we decreased the dose of Myfortic from 720 BID, 360 BID, 180 BID. But the problem now, just patient not responding. And one patient we shifted 1 month ago to azathioprine, and all symptoms resolved completely. And the other patient, just we are trying now just to decrease the dose of Myfortic to 360 BID, and we'll see the response after 2 weeks. If not improved, just will transfer to azathioprine 1 to 2 milligram per kg. Some side effects for mycophenolate or myfortic: cytopenias, hair loss, and teratogenicity if childbearing or pregnant women. Little bit take care from this. Any sexually active women should be on dual contraception medication to avoid any teratogenicity, and they should cancel any childbearing female. For any pregnancy in future, she should inform the transplant clinic teams or transplant doctor. Mycophenolic acid toxicity, GI intolerance, as we mentioned, diarrhea, not related to local effect, not clearly related to mycophenolic area under the curve, nausea, vomiting, esophagitis, gastritis, diarrhea. This toxicity really sometimes some patient horrible and diagnosed by colonoscopy and the biopsy. This cover MMF related colitis already for most of the patient. When some patient leukopenia, thrombocytopenia, anemia related to MMF, and you just responding to the decreased dose or hold the dose, and congenital malformation contraindication in pregnancy women. And this slide just again, mycophenolic exposure increased during the first year post transplant, and some centers just after 3 months of the kidney transplant with stable graft function with no rejection, they decrease the dose. For example, if your patient on myfortic 720 BID, they decrease to 720 and 360 after 3 months, just to decrease the risk for infection, especially for BK virus nephropathy. And because maybe just decrease the clearance or as your patient, if better if you have this MMF level in your blood, it will guide you just to keep the same dose or increase the dose, especially if you have high serum level of MMF. Better to decrease to keep your patient safe from BK virus nephropathy after transplant. As I told you before, CellCept. I will not mention mycophenolate mofetil for the time, and myfortic mycophenolate sodium enteric-coated capsules. CellCept is a prodrug, inactive drug, but myfortic is active drug. CellCept require acidic environment for cleavage into the active form in the stomach. So food interaction, you should be away from the food, and the pantoprazole or PPI will interfere with absorption of this medication. But myfortic already more pH stable versus MMF. Incidence of diarrhea same with both, but it's most of the expert opinion, and in some cases already will better GI side effect in comparison by CellCept. No interaction with iron, MMF, and enteric is both similar efficacy and safety, but mycophenolate sodium enteric coated formulation just more better GI tolerability and better less side effects than in comparison by CellCept. Some but not all studies found this enteric-coated powder less side GI effect in comparison by CellCept for enteric-coated mycophenolate sodium myfortic. As regard MMF-induced diarrhea, usually the diarrhea starting after 2 weeks at least from the starting of this medication, or some patient just maybe from the first week or after 1 week, but commonly to be started after 2 weeks. And usually what we are doing just decreasing the dose, splitting the dose. If he's taking 720 myfortic BID, because will it change now from inhibition diarrhea, will it change to myfortic little bit less GI side effect. Usually we are decreasing from 720 BID to 360 BID to 180 BID. And if there's no response after that, you should transfer your patient to azathioprine. But don't forget, azathioprine and allopurinol interaction will come to this point. But before blame this MMF-induced diarrhea, you should do all virology screen, stool analysis for oviparasite and Shigella, E. coli, and Enterococcus. But any Campylobacter also, any bacteria or virus can induce this diarrhea. You should rule out all this. After that, you can decide to decrease the dose or shift your patient to azathioprine. And if you are facility to do colonoscopy and the biopsy to be taken to rule out either MMF-induced colitis or CMV-induced colitis by biopsy taken and histopathology analysis. it will be a good idea for definitive diagnosis and future plan for your patient if your patient with persistent diarrhea. Other adverse effect or side effect, as we mentioned, pancytopenia, and we should first hold septra and valgancyclovir, and finally you can decrease his myfortic dose, and if no response, just we can hold this medication and we see the response. And most of the patient during admission after transplant receiving ATG, almituzumab induction, this maybe also can do pancytopenia better, just watch and observe after and we can hold the medication a little bit or decrease the dose, and we'll see what is the response after that. Dosing and administration, already we mentioned already, we can use either Cellcept 1 gram BID from day one, or we can use, sorry, I guess I'll connect my charger, or we can use mycophenolate mofetil. We can use this Cellcept either 1 gram BID from day one or post-operative direct, or myfortic 720 BID. And the dose may be reduced. This depends on tolerability and the therapeutic level. If you can do therapeutic level, you can increase or decrease your dose, and to keep your patient safe from any rejection or whatever type of rejection will be happen. Just take care from proton pump inhibitors, antacid in general. Also with ranitidine, because if you are using Cellcept mycophenolate mofetil, it will love this medication. It loves the acidic media to for cleavage and start working. Cholestyramine, sevelamer, and oral ferrous sulfate also can interfere with absorption of this Cellcept. On enteric coated patient is, I think, is not affected by PPI or antacid. So enteric coated mycophenolate sodium as myfortic is preferred over MMF if your patient dependent on PPI, like patient with peptic ulcer disease or GI bleeding before transplant and he's already on pantoprazole. Here, this slide, when azathioprine used, if the patient, as I told you in clinic today, if not responding to the decreased dose of myfortic, because we shift here from Cellcept to myfortic, and we decreasing the dose of myfortic. If no respond on lower dose of myfortic, because we prefer myfortic or Cellcept better than azathioprine, because azathioprine is a retired medication or eldest medication, older medication now, and no one using, but we just close our eyes and using if this patient still with horrible diarrhea interfering with his social activity, with your patient's social activity, we'll go ahead with azathioprine at that time and just to observe CBC and liver function after, especially 1 week after starting this medication. And we know azathioprine already preferred with any pregnant lady. We'll go now to this retired medication, azathioprine Imuran. Is a prodrug converted to 6 mercaptopurines, purine analogs, prevent DNA senses, and de novo purine senses. Used also in immunosuppression kidney transplant if we can't use MMF or mycophenolate sodium. Target rapidly dividing lymphocyte. Will come to this mechanism of action now. His metabolic pathways little bit confusing, but I need from you just to know. We have from exenzine oxidase enzymes. It will transfer to 6 uric acid is an inactive metabolite, and the cypirine methyl transferase will transfer to 6-mercaptopurine, whatever inactive metabolites. And this active one, I need you to just remember this one, 6-thioguanine nucleotide. This is the active form or active metabolite from this azathioprine. After all, in oral intake, it will change it to 6-mercaptopurine. This active form, it will end by this 6-thioguanine nucleotide. This is what I need you to remember. azathioprine inactive form, 6-mercaptopurine also inactive, and you will convert it to 6-thioguanine nucleotides. This is responsible for cytotoxicity and myelotoxicity. And as I mentioned, you will take this azathioprine to 6-mercaptopurine and will end by this 6-thioguanine nucleotides. This only from this diagram. Just remember azathioprine, 6-mercaptopurine, and this one will transfer by xanthine oxidase inhibitor, dehydrogenase enzymes. If you block this by allopurinol, it will end by toxicity of this azathioprine in your blood and will end by this cytotoxicity here. But because we are taking 6-mercapto and it will be transferred to inactive metabolite 6-cyanouric acid or whatever, this what I am showing here. If you will give allopurinol with azathioprine, it will make more toxicity from this medication, and this will prevent transfer this one to this one, and the cycle will continue in this pathway to 6-thioguanine nucleotide. This will be myelosuppression, cytotoxicity, and hepatotoxicity, or whatever. This circle already would like to reach to this stage. And by azathioprine, just we are blocking all these pathways. Now the active metabolite 6-thioguanine nucleotide effect act as the false purines incorporated into DNA damage and replication block, inhibit lymphocyte proliferation, T and P cell suppression, purine senses, decrease building block of our DNA, block to cell signaling, and reduce leukocyte adhesions. As we mentioned, azathioprine rarely used in current practice if we start with MMF side effect, and usually starting dose 1 to 2 milligram, but it's best to start 1.5 milligram per kg daily. And you know the tablet around 25. If your patient 65, you can give him 75, or 70, just to give 75, or 60, you can give just 50, whatever, because it is a tablet form around 50, 25. Interaction, we know this myelosuppression is common, as we mentioned before. Interaction, just allopurinol for xanthine oxidase inhibitor, increase the toxicity. Steroid and azathioprine, take care. Don't forget pancreatitis if your patient came by upper GI abscess. Just remember azathioprine can lead to pancreatitis. Use with caution with other DNA synthesis inhibitor like cyclophosphamide. It will be more myelotoxicity and side effect from combination of these medications. And this is the most common adverse effect of azathioprine: leukopenia, almost around 25%, myelosuppression, hepatotoxicity, pancreatitis, and gastric intolerance also is increased. Also non-melanoma skin cancer and lymphoma as a side effect for this medication. Azathioprine prodrug, and it will transfer to active metabolite 6-thioguanine nucleotides, block DNA synthesis and lymphocyte proliferation, and need close monitoring. Also, usually they before in remote, when they started this aspirin in 1980s, they just depend on, because we can't monitoring the blood levels, they depend on the WBCs. Leukopenia as a side effect from this medication means you have a good blood level or target blood level. Just they depend on the issue for bone marrow suppression and the leukopenia to guide them we are in the right dose or whatever. They continue increase the dose according to change on his CBC parameters. And this again mechanism of immunosuppression as a azathioprine playing here for DNA purine inhibitor already, and this will do suppression for cell cycle. And again here, just to simplify everything, as a azathioprine converted to 6-mercaptopurine, and this will transfer to 6-thioguanine nucleotide. And this, I think this is the easiest diagram for you to remember. Azathioprine to 6-mercaptopurine to 6-thioguanine nucleotide, and this responsible for purine synthesis and DNA replication. All this inhibited now by this azathioprine. Will inhibit all this cycle to reach to DNA transcription, translation, and replication of, and this will activate the cell cycle and the T cell proliferation. Also, MMF, mycophenolic acid, MMF cell receptor will transfer to myfortic, and this will inhibit enzyme monophosphate dehydrogenase, also play an purine synthesis, DNA replication, DNA transcription, and cell proliferation, and no more T cell activation. I think this is the easiest diagram for you to remember both mechanism of action. Again, the issue I'm just repeating here again to confirm this azathioprine, what will transfer to the 6 mercaptopurines, and this will end by 6 thioguanine nucleotides, and this will end by inhibition of DNA and RNA transcription translation, no more cell cycle proliferation. Again here, we just repeating for you to remember this 6 thioguanine inhibition, and just dose already 1 to 2 milligram per kg once daily, and non-dialyzable medication, non-renally excreted, just only monitoring CBC and liver function test within a week, maybe for two blood cycles, and you can repeat monthly to be sure no pancytopenia or no hepatitis after this medication start. Usually we prefer this medication in lady planning for family counseling or planning for pregnancy, or patient intolerance with low dose mycophenolate, whatever the Cellcept or Myfortic with diarrhea, and other side effects, skin lesion and skin cancer, melanoma skin cancer, as we mentioned, is the most common malignancy after transplant. Myelosuppression will follow this by CBC and hepatotoxicity. Pancreatitis is when the patient came on azathioprine with upper abdominal pain, just to rule out pancreatitis, hair loss. And don't forget, when you will put your patient on azathioprine and in nephrology in general, don't just write this clearly. Yes, for allopurinol or febuxostat or uric acid lowering agent should be contraindicated except after counseling with transplant team or general nephrology team, whatever who prescribe azathioprine, to keep this in future. Otherwise, some patient missed with this, it will with combination allopurinol with azathioprine, they will come by very bad pancytopenia and severe myelosuppression, and it's not good to miss this as a nephrologist or kidney transplant physician. As we mentioned again, toxicity, pancytopenia or myelosuppression, hepatitis, pancreatitis, interaction with allopurinol, you should decrease the azathioprine dose by 25 or 50%. It's better to reduce by 50% your dose of azathioprine if you are planning to start allopurinol for your patient, and just monitor white blood cells weekly at the start of your naive patient or new patient with on azathioprine. Just key clinical notes or pearls, mycophenolate better than azathioprine in efficacy. Keep this in your mind. Try mycophenolate lower dose better than converting or switching your patient on azathioprine. GI side effect often limit dosing. Start QID, convert to BID, as we mentioned before. To be careful with formulation equivalent, avoid indifferent substitution for those equivalent, like for example 360 myfortic equal to 500 BID Cellcept, 360 BID myfortic equal 500, 720 BID myfortic equal 1 gram from Cellcept. Azathioprine mainly reserved for MMF intolerance or cost concerns. And that I kept the table for you with each immunosuppression medication to remind you if your patient is sick or need ICU admission, how to transfer from oral form to IV form. And usually we are transferring this, as we mentioned, Myfortic 720, for example, BID will shift to 1 gram Cellcept IV, because we only have mycophenolate mofetil IV Cellcept. And thank you so much for your listening. والسلام عليكم ورحمة الله وبركاته. ولا تنسونا من صالح الدعاء، ولا تنسوا الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونلقاكم بفيديو قادم قريبا إن شاء الله. هنتكلم فضلنا موضوع السيرولوماس والأزر، وبعد السيرولوماس في أزر immunosuppression used in transplant. We'll speak on all in details. ونسالكم الدعاء بالتوفيق، ونلقاكم بفيديو قريب إن شاء الله. والسلام عليكم ورحمة الله وبركاته.